So you pick up your first chart of the day and you see the chief complaint is vaginal bleeding. And you're thinking, again, what am I going to do for this patient? What's my differential and what treatment can I give them?
And EMS brings in your next patient from the local nursing home with altered mental status and abnormal labs. They also hand you a stack of paperwork, including the lab, which is notable for a hyponatremia of 119. You wonder, how am I going to treat this? What is the calculation for this again?
In this episode of Critical Decisions in Emergency Medicine, we will talk about vaginal bleeding, specifically its differential and management.
We will also talk about hyponatremia in the ED, how to evaluate for the cause of the hyponatremia, and how to manage it.
With you is Dr. Danya Khoujah. I'm an emergency physician who practices mostly in Florida, a little bit in Ohio, and a little bit elsewhere.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington region.
And this is the September 2025 episode of Critical Decisions in Emergency Medicine podcast. Each month, we discuss the Critical Decisions publication, which includes 2 lessons that are bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the Critical ECG, the Clinical Pediatrics, the Drug Box, and Tox Box.
So for our first lesson this month, pulling back the curtain, vaginal bleeding, thank you to Doctors Ariana Rucker, Luis Miranda, Srinidhi Turnagaru, and Ronald Hall for writing this article.
You know, Danya, some days this feels like the most common presentation in the ED, but in actuality, it's only about 5% of total ED visits.
You're absolutely right. And there is a very long list of causes that can cause vaginal bleeding, which is probably why we feel like we see it a lot. There's a great table in the article that lists them all, but the most common ones are pregnancy, uterine polyps or fibroids, endometritis, coagulopathies, and trauma. Our number one priority in these patients are, of course, their ABCs. Are they hemodynamically stable or not? And then the question that comes up right after that, are they pregnant and is it an ectopic? And then the other things kind of fall in place. More of the history, more of the physical, the labs, and so on.
So let's start with the scariest then, ruptured ectopic pregnancy. What should raise our concern?
So any patient who is pregnant should have this diagnosis considered, period. Obviously, if the patient has risk factors, then our suspicion should increase. The most common risk factors that we tend to see in the emergency department are things like prior ectopic pregnancy. That's your number one risk. Tubal surgery, previous pelvic infection, use of IVF, congenital anomalies or tumors, and having an IUD in place. Obviously, the list is much longer. It's also important that we not limit this differential to people with a risk factor because they may have it, just don't know about it yet. Another thing to inquire about are risk factors for a heterotopic pregnancy. And a heterotopic pregnancy is basically when you have an intrauterine pregnancy and an ectopic pregnancy at the same time. The number one risk factor for that is IVF, gonadotropin medications. Those are in combination the most common ones. Having an intrauterine device, a previous ectopic pregnancy, a prior tubal surgery, all those also increase the risk for that. Remember that the patients may present with a rupture or not. And the goal is to identify them before they rupture. So anybody who comes in with sudden onset, severe and persistent abdominal pain or pelvic pain, if they're hemodynamically unstable, they're lightheaded, they're hypotensive, they're tachycardic, but some ruptured ectopics are going to be hemodynamically unstable with 0 abdominal signs or symptoms. Other tip-offs for this ruptured ectopic would be bradycardia from irritation of the peritoneal cavity that causes that vagal response. Or a patient can have Kerr's sign, which is shoulder pain caused by diaphragmatic irritation from the blood in the peritoneal cavity.
Definitely scary when one of these patients present. So how do we manage them?
So if they're ruptured, scary, but quite straightforward. You resuscitate them and you send them to the OR. If they're not ruptured, then it really depends on the size of the noted pregnancy or the noted ectopic, on the patient's fertility desires, and other factors regarding where you work. So you definitely need to work with your OB service to decide if the best next step for these patients is observation or medical treatment or surgical treatment.
Now, what about a patient who is not pregnant? I guess not to have to worry too much, right?
Well, some bleeding in non pregnant people may still be life threatening. Now, if it's considered heavy bleeding, which means, according to ACOG, changing pads or tampons every hour for more than 2 hours, then the patient is at risk of significant blood loss. Taking a step back and looking at all the differentials for bleeding in a non pregnant patient, ACOG has a mnemonic called PALM COIN, COIN as in COEIN. And that first part of it, the palm, represents the structural causes: polyp, adenomyosis, leiomyoma, which are fibroids, malignancy, and hyperplasia. The coin represents non-structural causes. The C is coagulopathy, O is ovulatory dysfunction, E is endometrial causes, I is iatrogenic causes, and N is not yet classified causes, which I think is the favorite cause of mine on that list. The most common cause of heavy bleeding is a fibroid, but the most common cause of bleeding overall is uterine bleeding related to ovulatory dysfunction, which can be due to fluctuations or disruptions in hormone levels. It's important that when we obtain a history from a patient who's non-pregnant coming in with vaginal bleeding, we inquire about any recent gynecologic procedures, such as a DNC, a surgical abortion, ablation, and so on, to make sure that this is not a post-procedure complication. Another thing that we need to think about is a possible hidden coagulation disorder, or a known one, of course. It is shown that up to 20% of women with heavy bleeding have an underlying coagulation disorder, with von Willebrand disease being the most common.
That's a really good reminder for sure. So, how do we treat non pregnant patients presenting with vaginal bleeding?
Well, it really depends on if it's heavy bleeding or not. Now, if it's heavy, obviously you need to correct the coagulopathy if present. You can give them high dose intravenous conjugated estrogen, which is 25 milligrams IV every 4 to 6 hours until bleeding diminishes or stops, in combination with fluid resuscitation and blood transfusion, as we said. TXA, 1 gram IV, is actually FDA approved for menorrhagia and can be added to this regimen to achieve hemostasis. If the patient is not having any life-threatening bleeding, then it's generally treated with a combination of oral contraceptives, NSAIDs, and progestins. And of course, if they have anemia, then an iron supplement may be necessary, and a referral to outpatient OBGYN for consideration of surgical options if needed.
We definitely love any application of TXA, and in this case, a very, very useful tool.
Of course you would, Wendy.
All right. The $1 million question, though, is not whether we should use TXA, but whether we have to do pelvic exams on all patients presenting with vaginal bleeding.
Well, the data is quite limited, actually. In patients coming in with severe bleeding and hemodynamic instability, it makes sense to do a pelvic and speculum examination to rule out a life-threatening etiology and perform resuscitative measures, as we're going to talk about later. If the patient is stable and pregnant, it's unlikely to make a difference, especially if ultrasound is available. There's actually a study that showed that in 94% of women who presented with abdominal pain or vaginal bleeding, the results of the pelvic were either predictable or had no effect on the clinical plan. So probably not necessary. Now, in patients who are coming in who are pregnant after 12 weeks, it's actually contraindicated to do a digital or speculum vaginal exam because these patients have an extensive differential other than the ectopic that we talked about earlier, which includes placental abruption, placenta previa, and vasa previa. And in these cases, with the placenta previa and vasa previa, the mechanical disruption from a pelvic examination can precipitate a catastrophic hemorrhage. So we need to do an ultrasound first. And if the ultrasound ruled out these diagnoses, then a sterile speculum examination can be performed, both to assess the bleeding, manage it if needed, and to determine if premature rupture of membrane is the cause of the presentation.
Let's talk a little bit more about the role of ultrasound in the second and third trimester patients presenting with vaginal bleeding.
Well, in addition to ruling out the dangerous diagnoses we just talked about, it is also used to assess for the fetal heart rate and gestational age, to look into the viability and possible differential at the time, the fetal positioning, to look for traumatic injuries, to look for obstetric causes of the abdominal pain and the vaginal bleeding, and to evaluate for non-obstetric causes if abdominal pain is also present.
Okay, now how about vaginal bleeding in a pediatric patient who has not had their menarche yet. How do we really approach these populations?
You give the chart to somebody else. So to me, that sounded quite scary. But then going through this article, it definitely does simplify the differential here. Trauma is the number one cause, as we probably would think of. And most vulvovaginal trauma is actually blunt. And it comes in with labral bruising or lacerations from things like bed frames, bicycles, playground equipment, bathtub fixtures. All can cause unintentional injury. Foreign bodies as well can cause vaginal bleeding. Penetrating trauma from coitus, narrow sharp objects, or water jets can cause vaginal bleeding as well. And it's important to remember that penetrating trauma can lead to internal rectovaginal wall lacerations that can be life-threatening and cause peritonitis, even when there's no external injuries available, which is why it's extremely important that the perineum is examined in hemodynamically stable patients and strongly consider consulting a surgical specialist for examination under anesthesia. As for our bedside examination, the vulva, hymen, and anterior vagina can be visualized through gentle lateral or anterior traction of the labia. And, great pearl here, otoscopes can also provide focused illumination and magnification if needed. Of course, it's extremely important for us to consider sexual assault, and a thorough history must be obtained, which may include assessing the patient without the caregiver and obtaining collateral history. It's also important to remember that our non-traumatic causes for vaginal bleeding in pediatric patients, such as neonatal vaginal bleeding in patients that are 1 week old, that comes from withdrawal of maternal estrogen that crosses the placenta. It could be things like bacterial vaginitis, which is caused by strep or shigella, again, different than etiology in adults, and lichen sclerosis. Other things that are incredibly rare, but to think about as well, are genital tract malignancies, precocious puberty, genital warts, and external estrogen exposure.
What about managing these injuries? How do we approach that?
So for simple traumatic injuries, such as vulvar hematoma, they can be managed with ice, analgesia, and bladder drainage. And sitz baths can be recommended to keep the area clean. Small lacerations that are less than 3 centimeters in size that are limited to the vulva do not require suturing and can be bandaged with topical emollient. Obviously, anything more complex than that would involve a specialist.
Now let's talk a little bit about postpartum and post-abortion hemorrhage. What are some common causes and how do we manage these?
So, postpartum hemorrhage is considered primary if it occurs within the first 24 hours of birth. But if it occurs over 24 hours up to 12 weeks, it would be considered secondary. For the primary, the number one cause is uterine atony. Other things are trauma, retained products of conception, and coagulopathy. As for secondary causes, your number one cause here is a retained product of conception. Other things include endometritis and subinvolution of the placental site. For post-abortion hemorrhage, the causes are similar. However, it's important to consider that the patient may have undergone an unsafe abortion and may be more likely to have a structural cause for that bleeding, especially if it were, again, an unsafe situation. What's interesting that I learned from the article as well is that surgically induced abortions have less bleeding than medically induced abortions, like half.
Oh, that is interesting indeed.
Now, the management really depends on how much bleeding there is. If we're talking about a lot of bleeding, like 1,500 mLs or more, then it needs to be aggressively treated. If the bleeding is due to uterine atony, then uterotonics such as oxytocin, methyl-argonovin, or 15-methyl prostaglandin, misoprostol, those are all considered first-line treatments. And we can use multiple uterotonics back-to-back if needed. And of course, TXA is here to the rescue as well. If those things are not working, then second-line treatment include tamponade techniques, such as the use of an intrauterine tamponade balloon, intrauterine packing, suction tamponade devices, or bimanual uterine massage. If the cause is not uterine atony but something like endometritis, then these patients need to be treated with broad-spectrum antibiotics, specifically clindamycin and gentamicin if possible. If the cause is a laceration, then pressure needs to be applied to the laceration, and it should be, if possible, repaired by an experienced physician. And they would be repaired using absorbable sutures with a figure of 8 or a running stitch.
Well, thank you, Danya, for taking us through this lesson. Certainly a lot of great pearls and refreshers. As we mentioned, there's many different causes for patients who are presenting with vaginal bleeding. The number one cause we should consider is, of course, whether the patient may be pregnant. But for non-pregnant patients, common causes include fibroids and ovulatory dysfunction. Really approaching these patients is like any other critically ill patient, which is looking at our ABCs. Now, if a patient is pregnant, coming in with hemodynamic instability, one thing we often have to consider is ectopic pregnancy. And so definitely have a high index of suspicion for these patients and to rule out an ectopic pregnancy. The article shared a great mnemonic, palm coin, to try and help think about all the other different causes of vaginal bleeding in non-pregnant patients. And that's really dividing it into structural causes as well as non-structural causes. One great pearl that I took away is that a lot of times women presenting with vaginal bleeding may have underlying coagulopathy, with von Willebrand's disease being the most common. So thinking about a workup for that is also important. Now, in terms of management, it really depends on the cause of the bleeding to target your treatment. As we heard, tranexamic acid is a great tool to have that can be used for menorrhagia or massive bleeding of a GYN source. But if we are dealing with ovulatory dysfunction, then certainly a lot of times we think about estrogen. If we're thinking about postpartum bleeding, then we're thinking about potentially needing uterotonics, whether that might be oxytocin, ergots, or even misoprostol. Now, specific to postpartum and post-abortion bleeding, if in addition to resuscitating the patient with blood products and the use of uterotonics, sometimes we may even have to utilize tamponade techniques to help treat the hemorrhage as a second line option. And that might include an intrauterine balloon tamponade or even packing. In terms of pediatric patients who have not had menarche presenting with vaginal bleeding, things we have to consider are trauma, and then always have to think in the back of our mind of whether sexual assault may be a concern. So that requires, of course, a thorough history, which may include assessing the patient without the caregiver present and obtaining collateral history as needed. I think all of us might be not as comfortable with performing the exam, but you can do an external visualization of the vulva, hymen, and anterior vagina through just gentle retraction of the labia to then decide if the patient requires further examination under anesthesia. So definitely check out the article for a lot more pearls on how to manage your next patient with vaginal bleeding.
Thank you, Wendy, for summarizing this article. Moving on to a different topic, our critical ECG this month is an ECG of an 18-year-old man who is presenting with palpitations. And then when you look at his ECG, you get palpitations too, because it is quite scary looking. The patient has a very rapid, regular, narrow complex tachycardia with no P waves. The rate is around 250 beats per minute. And then you note that the patient has a terminal R wave with SC segment elevation in lead AVR. Of course, you think of all of your differentials for your tachycardia, but it's not sinus tach, it's not atrial flutter. You think maybe it's paroxysmal SVT, but then you realize that this is most likely orthodromic AVRT, which is the most common dysrhythmia encountered in patients with WPW. The tip-offs were the fact that the heart rate was very rapid, so above 200 to 220, and that it was quite irregular, and that it is narrow. The article goes through a detailed description of what arrhythmias happen in WPW, why they happen, and how to differentiate them. Definitely a great review. It's important to remember that it may be difficult to distinguish orthodromic AVRT from paroxysmal SVT. However, fortunately, it doesn't necessarily matter. If patients cannot tolerate the arrhythmia and they're hemodynamically unstable, then synchronized cardioversion is for everybody. If they are hemodynamically stable, then you can give them adenosine. That doesn't work. Metoprolol or diltiazem is also appropriate. And of course, some people's favorite, procainamide. Definitely a scary EKG that reminds us of pretty important differentials. Moving on to a different topic, our clinical pediatrics this month is a child presenting with purple vesicles. It's a 15-month-old, previously healthy, fully immunized, who comes in with this progressively worsening rash in his face and left index finger for 8 days. And that started right after he got his 15-month vaccines. His physical exam reveals crusted yellow-brown lesions with erythematous borders around his perioral area, but no oral ulcers or mucosal involvement, or conjunctival injection. And his finger looks like a big purple, scary blob. The article has great and quite scary images of that finger.
So this is really consistent with herpetic whitlow, which is a viral infection of the distal phalanx, often caused by herpes simplex virus type 1 or type 2. HSV1 is the predominant cause of herpetic whitlow in children due to autoinoculation from oral lesions, while HSV2 is more common in adults, usually occurring through genital HSV transmission. The infection is usually self-limiting, resolving within 1 to 3 weeks, but there can be complications such as bacterial superinfection or even disseminated infection in immunocompromised patients. The diagnosis is clinical, but you can get a PCR test of that fluid. The important pearl is that you should not do an IND on these lesions because it can cause viremia and superinfection. Treatment with antivirals like acyclovir within 48 hours of presentation can shorten their symptoms and decrease viral shedding.
Other differentials to consider in a case like that are bacterial paronychia, dyshydrotic eczema, and bullous impetigo. So for our critical image this month, it's a case of an 18-year-old man with thumb pain after a hyperextension injury while playing football. And the x-ray showed dislocation of the MCP joint. He was initially seen in urgent care. They tried a reduction, but that was not successful. So they showed up to your emergency department.
Now, while MCP joint dislocations are quite rare, it's also interesting that when you try to reduce it just by simply traction, it's often unsuccessful, which then can cause more problems by entrapping the volar plate. And then the patient would need a surgical reduction. The issue is that x-rays, of course, can show the dislocations, but you really need to think about the tendons in that joint and the forces they are exerting. So to reduce these dislocations, you actually need to think about putting the patient's hand, wrist, thumb in a position that relaxes the tendons to reduce that resistance. For this particular patient, having their wrist in a neutral or extended position keeps those tendons in tension. Whereas if you were to position more in a flexion position, that will allow them to relax and that will help you successfully reduce the phalanx.
Great tips. There's nothing more annoying than a finger that does not want to go in place. Switching gears to something a lot more dramatic than dislocated fingers, our LLSA Literature review this month is about a 2022 International Society of Pediatric and Adolescent Diabetes Guidelines for diabetic ketoacidosis and hyperglycemic hyperosmolar state, published in Pediatric Diabetes.
Yeah, this is a good refresher. And specific to the 2022 guidelines, they included a threshold of having a serum bicarb of less than 18 to make the diagnosis of DKA. They recommend that fluid boluses should be given pretty rapidly, over 20 to 30 minutes. And then they also remove the requirement that the serum sodium concentration should be increased during DKA treatment. So, in terms of managing DKA, obviously we focus on correcting dehydration, acidosis, and ketosis while trying to normalize the patient's glucose and osmolality and preventing complications like cerebral edema. For fluid resuscitation, you can give normal saline, 10 to 20 cc's per kilo as a bolus, with the goal of replacing their total fluid deficit over the 24 and 48 hours. You want to actually avoid insulin boluses in pediatric patients. Instead, just start the drip at 0.05 to zero point 0.1 units per kilo per hour after you start the fluid resuscitation. And similar to adults, we do not recommend bicarb unless you're dealing with a life-threatening acidosis, such as with a pH is less than 6.9, and there's compromise to the cardiac function or very severe hyperkalemia. In peds, though, we're especially worried about cerebral injury, cerebral edema, And this is more common in younger children if they're presenting with very severe acidosis, hypocapnia, and an elevated BUN. If it occurs, you can give mannitol or hypertonic saline. Now, in terms of HHS treatment, we also want to provide fluid resuscitation because they are presenting with profound dehydration and sometimes even circulatory collapse. You do want to give an adequate amount, so at least 20 cc's per kilo initially, followed by 12 to 15% correction of their fluid deficit over the next 24 to 48 hours. You do want to hold on giving insulin until the glucose lowering slows down to less than 3 millimoles per liter per hour with just fluids alone. And you do also want to start with a lower rate, which the article recommends 0.025 to zero point 0.05 units per kilo per hour. Now, for HHS, the complications you're looking for are rhabdo, hyperthermia-like syndromes, and venous thrombosis.
Wow, a quick review of something that's quite scary and hopefully we don't see as often. Great summary of a great article. Switching gears to something completely different again. Our critical procedure this month is about spermatic cord block. And this can be used to manage scrotal pain in patients coming in with testicular torsion, epididymitis, and trauma. The idea is that you are trying to anesthetize the scrotal contents, but not the skin of the scrotum. So if the issue here is in the skin, this is not going to work. This can be performed as a blind block or using ultrasound guidance using a linear probe between the anterior superior iliac spine and the pubic tubercle.
To perform the block itself, if you're doing it without ultrasound guidance, your landmarks, as you mentioned, are the anterior superior iliac spine and the pubic tubercle. And you want to inject 5 to 15 cc's of your anesthetic of choice at 1 centimeter medial and below the level of the pubic tubercle.
Makes sense. Definitely something to keep in mind, but I'm not sure how excited I would be to do that on my next shift.
True. Now, let's talk a little bit more about orthopedics and trauma. In this month, we have a case of a 32-year-old pregnant woman with progressive plantar pain and swelling. Her exam shows swelling on the plantar surface at the first metatarsal. There's also tenderness on the plantar surface over the midfoot and great toe, and there's decreased range of motion of the first MTP joint. You get an x-ray and it shows an acute medial hallux sesamoid fracture.
Sesamoids are bones that are embedded within tendons at joint surfaces in the extremities, and they help with flexibility and they prevent the direct stress on tendons during weight-bearing activities. Now, most fractures are stress fractures, but acute fractures can also occur in athletes from sudden twisting movements or forceful dorsiflexion.
To evaluate this, you can perform a passive axial compression test, which means you're going to apply firm pressure just proximal to the sesamoid points during passive dorsi and plantar flexion of the first MTP joint. This will reproduce the pain. X-rays, though, may actually overdiagnose fractures because some people actually have a normal variant of a bipartite sesamoid. Now, these generally do heal with conservative management, but if non-op management, such as with buddy taping, orthotics, or even a cast fails, then the patients may actually need a sesamoidectomy, which is a new thing I learned.
Never heard of it before, either myself. Moving on to our second lesson of this issue, unsalted hyponatremia management. Thank you to Drs. Kayla Edwards, Mike Chang, and Craig Mehta for writing this article. You know, we do see a lot of hyponatremia in the ED. It's like actually 3 to 10% of patients. But I don't think I can worry about all 10%. When should we worry, and how should we approach managing these patients?
Yeah, definitely. I feel like it's one of the more common lab abnormalities we see. And the problem is there's many different etiologies that can cause this. That article breaks it down into essentially thinking about 3 aspects of a patient presenting with hyponatremia. You want to think about the severity of the hyponatremia, the acuity of this abnormality, and then whether it's really a salt or a water problem. Now, severity, I think we're all familiar with. You can classify it based on the actual sodium concentration. So a sodium level of 130 to 135 milliequivalents would be considered mild hyponatremia, whereas moderate is 125 to 129, and severe is less than 125. The trouble is that not all patients will present with a similar severity of symptoms just based on those values. The grading of clinical symptoms ranges from mild symptoms like unsteadiness, concentration issues, maybe some cognitive deficits, and progresses to headache, nausea, and ultramental status with moderate severity hyponatremia. And then the most severe cases, of course, can be seizures and coma and even cardiopulmonary compromise. Now, in terms of acuity, I think we're all familiar with this. Acute onset hyponatremia is really something that develops in less than 48 hours, whereas chronic is probably what we may see sometimes more often in, again, our chronically ill, maybe older population and such. They are the ones that have higher risk of overcorrection, which can cause the osmotic demyelination that we worry so much about. Now, the third part is the toughest part because you're trying to figure out what is really the underlying problem, a salt or a water problem, and that requires assessing the patient's volume status and their tonicity, which you can do by obtaining a serum osmolality.
That's a great way to simplify the beginning of this approach. So, what are some common causes of hyponatremia?
I think all of us can definitely rattle off a list of many things that cause hyponatremia. And so, really, by starting with thinking about the patient's volume status, help you kind of think about it in buckets. And so, patients who have hypervolemic hyponatremia really have an increase in free water. And this generally occurs in CHF, nephrotic syndrome, and cirrhosis because there's activation of the renin, angiotensin, aldosterone system that increases sodium and water retention. Patients who are euvolemic, they have an impaired water regulation, and that's usually due to endocrine problems or even dietary causes. We all know that ADH stimulates water retention, and increased ADH activity can be seen in SIADH, which are related with malignancies and medications like anticonvulsants and antidepressants. This can also be seen in severe hypothyroidism as well as Addison's. In terms of dietary causes, we often think about primary polydipsia and beer potomania because that causes a dilutional hyponatremia from taking in lots of hypotonic fluids. And those who actually present with that classic tea and toast diet have hyponatremia because they have a low intake of solutes. And in the third category of hypovolemic hyponatremia, these patients have more solute than water loss, but both are lost in some mechanism. This can happen from severe vomiting and diarrhea, or maybe they have some sort of a salt wasting nephropathy, sometimes related with chemotherapy, or simply overuse of diuretics. We do want to also mention that we can see a pseudo hyponatremia, which we classically see with hyperglycemia, but it can also be seen with hypertriglyceridemia and hyperproteinemia. And that's where these high osmotic substances causes really a lab artifact.
Got it. I don't think I've really thought of tea and toast diet as a cause of hyponatremia. I do not think it's a billable diagnosis, but I will try that on my next shift. So, how do we evaluate them? You did mention that we need to figure out their intake and the chronicity of the symptoms and so on. But what else do we need to do?
So I think some of the history can definitely shed some light into the type of symptoms they've been having, how much fluid and dietary intake is playing a role, as well as, of course, their existing medical history and medications. Now, in terms of specific laboratory evaluation, this is where getting a serum osmolality, a urine osmolality, and a urine sodium level can help you further differentiate. And in the article, there's a wonderful figure that walks through the steps. So definitely take a look. To summarize the general concepts, when you start with the serum osmolality, if you have a high serum osmolality, then it's most commonly related to the pseudo hyponatremia from this high osmotic substance of some other sort. That means the rest of the hyponatremias generally all present with low serum osmolality. So then the second lab, in terms of getting a urine osmolality, can help you differentiate between primary polydipsia versus, again, the remaining big list of differential diagnosis. So that really leaves the majority of the patients we're seeing with low serum osmolality, which is a hypotonic state, a normal or high urine osmolality. And then by you assessing their volume status and their urine sodium level, That will help you differentiate between all of those different etiologies, whether it's CHF, whether it's SIADH, etc. So definitely check out the figure to walk through the steps and help you figure out what's the cause.
Great reminder for us to order these urine osmols. So, how do we manage hyponatremia?
Well, not every patient with hyponatremia require correction. And so again, it goes back to their symptoms and their acuity. And there's also a great synopsis in the article in Table 3. If they're presenting acutely and they're symptomatic and it's severe, then you would give hypertonic saline. And the goal is to improve their symptoms and increase the serum sodium by about 5 milliequivalents. The guidelines suggest you can give about 100 to 150 mLs of 3% hypertonic saline and repeat as needed to achieve your goal. If the patient is presenting with a chronic asymptomatic hyponatremia, then your treatment depends on their volume status, whether you're going to restrict fluid or give fluid. The biggest concern, of course, is with overcorrection. And the guideline and what we are always taught is that you don't want to correct more than 10 milliequivalents in a 24-hour period in a patient with chronic hyponatremia, because that rapid change in the patient's tonicity is what puts them at risk for that osmotic demyelination. Now, if you do somehow overshoot and have encountered a situation where their sodium raises more than 10 milliequivalents in 24-hour period, you can then try and lower it back down with some D5 water or even some desmopressin to help slow down that correction.
Great reminder to not get overly excited and overcorrect. So, which patients require ICU admission?
Whew, my favorite question, since I get that request all the time. It really depends on their severity and their acuity of symptoms. Those with severe symptoms require the close monitoring and the frequent labs to really monitor that rate of correction.
Makes sense. Now I'll have a clear script to tell you next time I want to admit a patient to you to your ICU.
For you, anyone, okay?
Aw, well, thank you. Well, thank you, Wendy, for taking the time to go through this article. It was such a great reminder of something that we see quite often, but sometimes can be a lot scarier than it usually is and quite critical. It's a great reminder that when thinking of hyponatremia, we got to think about it in terms of severity and acuity. Acute is really like 48 hours. And then the big determinant, is it a salt problem or a water problem? Is it too little salt or too much water? And that helps us narrow down the differential for hyponatremia. If they have too much water, then they have hypervolemic hyponatremia. That's your CHF, nephrotic syndrome, and cirrhosis. They may have just enough water, and they're your euvolemic hyponatremic, who have impaired water regulation from endocrine and dietary causes. Ask about that tea and toast. And then your hypovolemic hyponatremic, those are the ones that have more solute loss than water loss, vomiting and diarrhea, salt wasting nephropathy from chemo, and overuse of diuretics. And then, of course, remember the trick, your pseudo hyponatremia, which could be like a lab artifact. They pulled it from a line that already has fluids running or something, hyperglycemia, hypertriglyceridemia. So don't believe everything you see. When these patients present, we do need to figure out from the symptoms, from their past history and meds, the acuity and what type we're dealing with. And things that can help us are serum osmolality, urine osmolality, and urine sodium level. Piecing it all together will allow us to figure out where the issue is. And not everybody requires correction. It depends on the symptoms and acuity. If they're acute and symptomatic and severe, that's your 3% hypertonic saline. Improve symptoms, up their sodium by 5. If it's chronic and asymptomatic, just leave it alone and focus on fixing the volume status. And if they're hypovolemic, give them an isotonic crystalloid. If they're euvolemic, hypervolemic, then restrict the volume and hold the medicines if that's the problem. And beware of overcorrection. Obviously, patients with severe symptoms, call Wendy or whatever ICU is closer to you than Wendy's and admit them there, because these patients require close monitoring and frequent labs to avoid overcorrection.
That's right. Although we're at capacity, so I can only take your patients, Danya. So now moving on to our drug box this month, droperidol. We're all familiar with this. It's often used for rapid control of acute agitation in the ED, also for nausea, vomiting, and benign headaches or migraines. Now, it's the dopamine antagonist mechanism that provides the antipsychotic and antiemetic effects, but don't forget that there's also some alpha blockade that can cause vasodilation and hypotension. The big thing we often talk about with droperidol is the dose-dependent QT prolongation with the rare incidence of torsades. So you do want to monitor patients with known or risk of QT prolongation very closely, also those with electrolyte abnormalities. There have also actually been some case reports of NMS, neuroleptic malignant syndrome too, so be on the lookout for that. And then just a refresher on dosing for nausea vomiting, typically we give 0.625 to 1.25 milligrams, either IV or IM. For acute agitation, you can give 5 to 10 milligrams IM or 2.5 to 5 milligrams IV.
Great reminder for a medication that is finally becoming more and more available. And I'm not sure about you, but that makes me happy. Last but not least, our Tox Box this month is about barium toxicity. And barium is a heavy alkaline earth metal that's used in textile dyes, ceramics, glass, rodenticides, and radio contrast. Acute toxicity occurs after intentional ingestion of the soluble barium salts, and that can cause intracellular shift of potassium that leads to muscle paralysis. Also, it works on the vascular potassium channels that leads to vasoconstriction and lactate elevation. Patients present with abdominal pain, nausea, vomiting, rhabdomyolysis, flaccid paralysis, respiratory failure, dysrhythmias, seizures, and altered mental status. If their potassium levels are low, so below 3, within 2 hours post-ingestion, that suggests severe toxicity. When the patients present, our first thing is always to decontaminate. Interestingly, you can do a lavage in this patient's or use magnesium sulfate. You need to aggressively replete the hypokalemia. Patients may need their airway protected and they may need to be intubated. They may also need hemodialysis. If the patient's asymptomatic and their potassium is normal at 6 hours post-ingestion, they can be cleared. Well, thank you, Wendy, for taking the time to go through this issue with me. I've learned a lot. Our dear listeners, we hope you've enjoyed listening to us as much as we've enjoyed recording this.
We hope you find the Critical Decisions publication and our podcast always informative, often enlightening, and never boring.
Reach out to us on social media. My handle on Instagram is @Dr. Danya Khoujah.
Mine is @Dr. Wendy Chang.
And until next month.
Bye-bye.